My name is Susan. I'm going to be presenting the last portion of your EKG and monitoring course. This is just a real quick case study, just to test your knowledge and see if you remember anything. With me today, I have Michael and Steve. Both have extensive cardiac experience in the cardiac cath lab. And so we're just going to go ahead and start. If you guys could all go to menti.com and enter the code 150309 on your phones. It will help you with taking the one little test question we have here. Let's get the big screen out. Okay. While you're doing that, our first case study is AS. She's a 54-year-old female. She's a non-smoker, non-drinker who presented to your ER this morning with 6 out of 10 mid-back pain, which she said started about an hour ago while she was cleaning. Blood pressure on admission was 168/92. Her O2 sat's good at 98%. She's on 2 liters nasal cannula. She is nauseated, but she isn't vomiting at all. They did an I-stat troponin immediately on admission. It was 0.02. BMP results are within normal limits. Ambulance gave her 324 milligrams of aspirin. The EKG was done. So I'm going to have you look at this EKG and see if you can identify what is going on with it. So if you take notice, we do have some ST segment elevations in V2, 3, and 4. So we're going to go and I'm going to ask you if it's an anterior lateral, or a lateral MI based on those EKG criteria. What does your phone say? Can you look at your phones and see if you can vote? See where we are up? One person voted. 2 people voted. Yay! And you are correct. It is an acute anterior lateral MI. And like I said, we are seeing the anterior leads are V2, 3, and 4. And the lateral leads in this case are a slight ST segment elevation in lead 1 and also in lead AVL. This lady did go on to have an MI alert, and cath lab came in. They stented her proximal LAD. Post-procedure, she went home on clopidogrel, atorvastatin, and aspirin, and was started a cardiac rehab program and some lifestyle management. The second case study is DM. He's status post-PTC of his LAD. They did use a bare metal stent because of some upcoming surgery that he was going to be having. He is in your cath lab waiting area right now, post-procedure, and he calls and says he has 7 out of 10 chest pain. He is diaphoretic and pale. Blood pressure was 101/64. Now this is an interesting EKG, and this is what it looks like. In this EKG, you don't see any of the traditional ST segment elevation, but you are seeing ST segment depression with a curved ST segment going into a hyperacute tall T wave. This is actually called De Winter T waves, and they are indicative of an anterior STEMI. There is an upsloping of the ST segment, and it is depressed in the precordial leads. If you look in all of the precordial leads, 2, 3, 4, 5, a little bit 6 too. And again, there's tall symmetric T waves. This actually occurs in approximately 2% of the LAD occlusions, but it is frequently missed because people are looking for the standard ST segment elevation when they're looking for a STEMI. And actually this man ended up going back and had a clot form in his bare metal stent and needed urgent revascularization. This, on first glance, is one of the reasons we always tell people to make sure lead placement is good and skin prep is good. This, at first glance, if you would only be monitoring 2 leads, you would automatically think this was VTAC and you'd be running back to see the patient. But in fact, if you look where my pointer is right now, those are actually QRSs, and you could actually map them out if you wanted to. You could march those QRSs through and see that they actually exist in everything that looks like a VTAC wave. Even down here you can see a QRS peeking through. So proper lead placement. This is actually muscle artifact on a patient with tremors. So we'll never know everything about EKGs, and we're not expected to. What we always need to do right, though, is good skin prep and lead placement. We need to be able to always recognize and respond to our hemodynamically unstable rhythms. We need to recognize and respond to acute ischemia, and we need always to treat the patient and not the monitor. Now, do you have any questions?
No.
No. What about you? No, Steve? Thank you very much. That's it. Thank you. And that is a